Stanton here with ACEP Frontline, and today we're here at our Indy class, so the Independent Group Academy Master Class here at the ACEP headquarters in Dallas, Fort Worth, just right off the end of the runway here, so you may hear a little airplane action. But we're here today. Dr. Gary Katz is one of the speakers and educators here, and the whole purpose of the course is really kind of helping emergency physicians with regard to creating, building, maintaining a small group structure, the things we didn't learn in medical school and residency. And Dr. Katz has experience with a group that's probably holds true for a lot of us out there, which is it's not going to be the large urban tertiary care center. It's not going to be, super rural. It's going to be somewhere in between, the community hospital settings that are in between, and helping, with staffing and some of the things to keep in mind when we do those, where you have that core. And the goal of a lot of this is saying we want to have that local investment in our groups run by emergency physicians, but then what are some of the challenges and things that we're going to do to help get past that? So give us a little background on where you're working. And
yeah, thank you so much. Thank you for the opportunity to be here, for the invitation to
it was a short invite. It was exactly 10 minutes. I texted him at lunch.
That's right.
When? Now?
I think I cut you off in line at the lunch line, and now I'm paying the price.
Yeah, it happens.
So,
it happens.
So we started our group back in 2018. I had been in practice for a couple of decades and really saw an opportunity to better serve our rural communities with emergency medicine. And I felt that some of the large groups were not serving that population well. These are hospitals that have volumes of 10,000 or 15,000. And when you put those on a spreadsheet against hospitals that have volumes of 50, 60, 80, 100,000, it's hard for some of those communities to get the attention they need to bring the best practices out to those communities. And so we started the group with the concept of, if we invest in those communities in a way that is meaningful to the hospital, to the patient, and to the physician, then we're going to drive more success into those communities, maybe even keep more patient care there locally. And that's exactly what we've been able to do.
And that's going to be very attractive for the hospitals, because now they're keeping that payer source patients within their facility. And of course, it's a big patient and family satisfier, because people are getting to stay close, not driving an hour to a big city center. Because I think you were saying most of your centers are about an hour to two from what we would consider one of the larger Ohio cities.
That's right. So each of our rural contracts, our rural and critical access hospitals contracts from a major city, whether that be Dayton or Columbus, Toledo, are probably an hour and 12 minutes. I had one site, it was 1 hour and 6 minutes. It did not matter how fast I drove or which route I took. It took the same amount of time. And so it was definitely opportunities to learn how to spend your time in the car well, whether that be listening to books or radio or talk shows, or just reflecting on a shift well done. So we're all kind of spread out of the city, which is an interesting dynamic. If I can say, one of the things that we had sought to do was to decrease that transfer rate. I mean, a lot of our hospitals, when we went into those communities, they were transferring about 16% of their patients. And we've been able to drive that down to about 9%, which means holding more of those patients in those local communities, which is the exact point that you made. But you made it from the point of the perspective of the patient, of like, hey, now grandma doesn't have to go an hour and a half to the big scary city to get her treatment, and I can maybe visit grandma after work rather than taking the day off from work in order to visit grandma in the hospital. That also makes a difference for the experience of the emergency physician. So often when we were going into these sites, the experience of the physician was, it's just easier to transfer the patient. Mm-hmm. And what kind of emergency medicine practice is that when all you're doing is hitting that transfer button? Sometimes it's nice, but it's not always emergency medicine that you're practicing then.
And you're doing a lot of air traffic control at that point.
That's right.
And so dive into a little bit of 2018 is when we're starting to focus on resources, having things available, trying to push, kind of shift to give more opportunities for physicians and hospitals out there, especially kind of the rebirth of the small democratic group. And here today, at this conference this week, it sold out in 5 days. There's huge interest in it. I've enjoyed it. I'm actually here as a student, and this time, and learning about these things with my relatively small group, 2 hospital group, of like how we work together to kind of make each other successful. But there wasn't as many resources. Then how did you kind of put that together when you saw this opportunity to say, I'm turning from physician into business entrepreneur?
Yeah. Never underestimate the power of the opportunity to learn from one's mistakes. So I did a lot of learning. And a lot of things that I tried to turn towards peers. Some of them are co-faculty here, and said, hey, how did you handle, where we started with 2 contracts, 2 14,000 volume hospital contracts, not really enough to have an in-house HR. But you still need HR. You need HR policies to protect you in case somebody acts bad. You need HR and payroll to make sure that you're managing taxes appropriately to the appropriate entities on payroll. How do you do that on your own? Or in our case, we leaned on friends in the industry to say, how can you guide us and give us an opportunity that we can afford to do?
And you mentioned many of these hospitals for you are about the same size, that 14,000 volume.
Yeah.
And you were talking yesterday about how that, from a physician standpoint, comes out to about 5.5 FTEs.
Yeah.
Talk a little bit about that, because ideally 5.5 FTEs, you hire 6 docs that live, work, stay there, and you've improved the access with local physicians there, emergency physicians, but you still have some outside work as well to kind of fill in some of the gaps. So kind of talk about that and some of the considerations, especially when we're cross-credentialing physicians at facilities that may be 5.5 FTEs, but now they got 35 applications.
As our contracts grew from new contract to more established, we saw a pretty consistent pattern emerge. At the start of the contract, we had difficulty filling those slots. At one point, I think we maybe had 25 or 30 bodies filling 5.5 positions. That's a lot of people to manage. Manage expectations, manage quality, manage experience for the physician, experience for the hospital. I had a conversation with the med staff office, which is really the brain center of a lot of hospitals. The MSO kind of controls the floodgates for who gets credentialed and who doesn't. And if we pile on, a half dozen or a dozen applications in a very short period of time, and they're all an emergency and need to be done right away, you get pushback from a small MSO of that's staffed by 1 or 2 hospital employees. So trying to manage that high turnover at the beginning of a contract, and then trying to hire right so that we were staffing full time with our, preferred individuals who buy into our group philosophy and into the model that we want to perpetuate over the long term. So now, after a contract has been in place for a couple of years, we find that we're probably about 4 full-time regular docs for those 5.5 FTEs, and then about a half dozen for that remaining FTE filled with part-timers or shared resources with our other contracts within the group.
You mentioned that number, when you first have them, of 20 to 25, there's a lot of impact, not just for the physicians, but also the consistency, the familiarity, the recognition of those that are actually invested in that particular facility.
Yeah, I mean, look, early in my career, as long as you had a stethoscope, you could show up to any emergency department and you could take care of patients just fine. And from a medical knowledge standpoint, that part still holds true. Mm-hmm. But process-wise, each hospital is different. Even small hospital is different. And particularly large urban center to small rural center, processes are different. Resources that are available are different. And if you don't have times at bat within that particular organization, your ability to function within that designed process is more and more difficult. So the sooner we can get to people having a regular cadence of appearance at that institution, the better the team runs, because a team that knows what all the players are going to do is going to function better than when somebody doesn't quite know what play is being called.
And when you do these types of things, and I've heard other people here at the conference talking about, if they've got multiple sites where somebody's going to do 75% of their time at this one, 20% at this one, and say 5% they may be floating around filling some holes and gaps. It sounds like you guys get a number of people that are kind of invested at that site only, but then how do you kind of manage that inevitable gap in coverage, whether it's just an extra shift, somebody's out sick, whatever happens, life happens, that you cover those types of things?
Yeah, well, our group philosophy has been to try to focus around what's good for the physician, because that translates to what's good for the patient. So we allow our physicians to select, this is my primary site, and we encourage people to pick at least one other site that they are cross-credentialed to so that they can help out. And that was a godsend of a philosophy to have last year. Again, among 5.5 FTEs, last summer we had somebody with a broken clavicle sliding into second. If you're 45 years old, don't slide into second base.
No.
The same week we had another doc go out for gallbladder surgery. The following week we had another doc, all at the same site, go out with a hip fracture. So we suddenly were scrambling to fill a whole bunch of FTEs of slots of people who got injured or sick, and you need to have that plan of being able to fill in from the side without making it compulsory in a way that people feel burdened by that responsibility.
Another thing that you're doing, I think most people that know you well know you about the military background, and you actually have a deployment coming up. How do you prepare, because that was part of the conversation we had right before lunch here today, was on some of that preparing, making sure that it's not dependent on one person to do everything, and then if that happens to go away for whatever reason, that now we've got a big vacuum. Now, how are you doing preparations as you kind of transition to head for your deployment and still come back?
Yeah, I mean, fortunately, I didn't have to make adjustments in my philosophy in order to manage my military responsibilities. I have always felt and promoted the concept of developing an heir and a spare. Basically meaning that you are, as a leader, responsible for finding people who are capable to replace you and doing that time and time and time again. Heir and a spare concept kind of conveys that it's just two people, but it's not. It's doing that iteratively over your career so that maybe 5, 6, 7, 8 people can replace you over time. So I've spent the last several years engaging in that concept, trying to make sure the medical directors who work with me are able to work even if I'm not available to them. And be self-sustaining. They all have relationships with each of the physicians. They understand what the contract limitations are for certain performance measures within the hospital and other aspects of our operations so that they can do the job without me there, and then, which makes my life easier most of the time, and then I can just be there to support them and help them feel successful in themselves. And then when there comes a time that I'm not available, it's just a matter of them, stepping into another gear for a brief period of time.
And we'll kind of wrap today with, you saw calling an opportunity because these hospitals were tired of what they had before. My hospital, we just expanded to a second setting because they had been wanting some stability and knew of our group and actually had tried to get us there for the last 6 or 8 years. And we finally got to the point where we think we are ready to take that step. And it was done very well. Again, learn from some mistakes. Some of those mistakes include things like letting somebody else see every little detail to the point that you're having to explain, the cost of a staple. But talking about that relationship, kind of the C-suite, bringing in the quality of a physician-owned local group of docs with an administration who's just looking for stability on something that, for the most part, alone may not be a money maker, but in terms of a hospital standpoint, the front door of the system, as well as the opportunity for your admissions, future visits, and keeping people in the family.
Yeah, I mean, we started talking about some of the metrics like transfer rates and so forth, and those are important metrics: door to doc time, door to head CT time and stroke, sepsis measures. These are all things that they're accountable for and are important, but quite frankly, performing well on those are expectations. They're entry level things. To get that real next level, like how are we satisfying the C-suite or the community, is to recognize that particularly in these rural and critical access communities, the CEOs respond very much to what they see on the street. And I mean that they are shopping at the local market, and somebody who was a patient just an hour ago is going to come up to them and say, hey, so-and-so took great care of me, or so-and-so did not take great care of me. And I guarantee you that C-suite person is going to call me on the way to their car to say, hey, I just heard news. And I'd rather them say, I just heard great news that Dr. Stanton took care of this patient and they loved him. And of course, you're surprised by that, right? So making sure that everyone buys into that recognition that these hospitals run their lifeblood on the community reputation and doing what we can to support their pride in their product.
And you mentioned, I said last thing, but one other thing popped in because you mentioned the community. In those smaller communities, it is much tighter. And you mentioned Rural King and Tractor Supply. I do know both of them. Tractor Supply quite often. But you talk about how, they're part of the community and being involved and engaging yourself as part of the community. Being part of like the sporting events, volunteering, health fairs, those types of things, of actually investing in the community. Because that's one thing I wanted to do with our group, my group, is expand some of that participation in things outside the hospital setting, but still very important to the C-suite.
Yeah, we would absolutely encourage that. So in an early iteration of our group, when we first founded, we actually paid a third of the incentive bonus at the end of the year based on people's participation in activities. We call it a citizenship or whatever you want to call it, but it was, are you going to, from the hospital perspective, going to a hospital committee? Are you participating in pharmacy and therapeutics? I don't really care which one it is. Whatever is important to you as the physician is the one you should be involved with. But we didn't keep it just to the community, because we provided that incentive reward also for people who were involved in something such as being the volunteer at the high school basketball events, for being the trainer to make sure that they had a safe environment. Whatever promoted that engagement between our physician group and our physicians, the patients we take care of, and the hospital in which we take care of them. And my belief is that that philosophy improved the experience for all members of that triad.
Yeah, completely agree. How can folks get in touch with you if they have any questions, thoughts, email, social media, whatever?
So I'm not big on social media, but you can always email me at gkatz@cempdocs, that's CEMPDOCS.com.
All right, Dr. Gary Katz here from our Indy class, the Independent Group Academy Master Class here in Dallas, Texas. And as for me, you can contact me, rstant@acep.org, rstant@acep.org, or at EverydayMed on X. And until next time, I'm Dr. Ryan Stanton. This has been some ACEP Frontline.